one of the things about my job as Public Health Minister is that it doesn't really matter who I'm speaking to or what I'm speaking about. The portfolio never really gets boring because the issues surrounding the public's health are always in flux. Really, the only thing that stays the same is the fact that there will always be challenges for us to deal with, and that, of course, is nothing new. And if you look at London, that's a good place to illustrate it. And I love my little historical references, so forgive me and indulge me for a minute. But 195 years ago, in 1816, Jane Austen had the general miasma of a large city in mind. She said that nobody is healthy in London and nobody can be. And 100 years before that, it was rubbish and sewage that concerned people. Jonathan Swift described a London rain shower as sweepings from butchers' stalls, dung, guts and blood, drowned puppies, stinking sprats, all drenched in mud, dead cats and turnip tops come tumbling down the flood. So a bit's changed, okay, we have made some improvements, but today we have our own problems. And if I think of just the last week, I have spoken about an incredibly diverse number of subjects. The very high instance of hepatitis C in South Asian communities, for instance, opportunities for midwives dealing with women who book very late in their pregnancies for improving the mother's mental health. The mental health and well-being of young girls so concerned now about their body image and so unconfident in many ways. Smoking, sexual health, immunisation and regulation, and I could keep going. And I think it's important to remember that successive governments have all given it a try, and to improve some of these issues and more besides, but as soon as we plug one hole, another seems to open up somewhere else. And it's not a lack of motivation, it's not a lack of will, it's because it's extraordinarily difficult to improve the public's health. It's clear that the old approach of seeing each problem as an individual issue with an individual response was not going to work, and all we have to do is to look at health inequalities that are still so entrenched in our society. Tim made reference to previous public health white paper, seeing everything very much in silos. And I think that we need to judge how successful we've been by how much we reduce inequalities. Like Michael Marmot demonstrated last year, that health gap between the rich and the poor has been widening. A man born in Kensington, for instance, can expect to live about 11 years longer than a man born in Blackpool. And a child with parents in manual occupations or unemployed has a risk of accidental or violent death about 5 times greater than that of a child with at least one parent in a professional or managerial job. And compared with older mothers, 3 times as many teenage mothers experience postnatal depression and are much more likely to suffer poor mental health years after the birth of their child. Statistics like that should actually continue to shock us, and there are an infinite number just like them. They tell us that we can't carry on looking at public health in the way that we have done, and we're talking about things that actually tear families apart, tear communities apart, and indeed society. So as Tim set out, we launched our public health white paper, and it set out the changes that we believe would help public health system better protect society's health. As I say, not looking at those problems in isolation, but by tackling the wider social determinants of health, if you like, the causes of bad public health. Things that aren't necessarily associated directly with health: poverty, unemployment, poor levels of education. Like in Haringey, where only 2 in every 5 5-year-olds were judged ready to start school. And in many ways that's nothing to do with health. It's about language skills, it's about personal development, it can be about other communication skills. But if a child isn't able to function well at school, their health will indeed suffer. They'll miss out on all the other stuff that children learn. So in our proposals, as many of you are aware, local directors of public health will work with other local bodies, including the NHS, including government, including business, including the voluntary sector, and on a huge variety of issues like housing, employment, crime, transport, and of course, health itself. And health and wellbeing boards will make that happen. They'll bring councillors, commissioners and public health representatives together to improve the lives of people in the area, develop proper strategies for health and wellbeing, including on public health, which will shape commissioning. I dream of seeing a day when councillors, rather than arguing across the council chamber about whether Mrs. Smith of 13 Arcacia Avenue gets a new porch on their house, they'll be arguing about the inequities that exist in the health of their populations and the life expectancy of their constituents. We want those health and wellbeing boards to integrate services properly, so we stop looking at hospitals or community services or GPs as another, carers as a third and so on, and instead see each part working towards the same aim, hand in hand, from hospital to homes and care homes to the community, with no one falling in between the gaps. And we need to make sure, of course, that sufficient funding, so that ring-fence public health budget from 2013. Money spent on public health will no longer get siphoned off to pay for other things. And that money coupled with the new health premiums. Nationally, the spotlight will fall on Public Health England, and it's a bit of a centrepiece, if you like, a new dedicated professional public health service that brings expertise into one place. An executive agency of the Department of Health, free to give entirely objective advice based on science, evidence, and nothing else. Terribly important that it has that integrity. And it will integrate the three pillars of public health: health protection, health improvement and health services, sharing knowledge, so as well as providing leadership in protecting the nation's health, we can protect our own health and well-being. Because at the moment, there's a lot of information that exists, but you do have to know where to look for it. It's a bit of a treasure hunt, really. Different websites, phone numbers, publications, and naturally a lot of anacronyms. The Department of Health, all of Whitehall loves its acronyms. The HPA, the NTA, the FSA, the SHA, the DATs, Public Health Observatories, Cancer Registries. There's a huge number of them. And there is, in fact, quite a lot of crossover in these groups. And so it makes sense to put them all in one place. And Public Health England will be that. There is a clarity in its name. It will make sure that all that information is available, accessible, and crucially, just for me, understandable. Not just to clinicians and practitioners, but most importantly, to the public. We have to start talking in a language that people understand. So more effective and more cost-effective, designed to make sure work is no longer replicated across lots of different organisations, with a tight structure and a very clear purpose that makes it easier to share knowledge and combat health threats. The recent E. coli outbreak showed us how important that is, and the Health Protection Agency staff were fantastic, deserve a round of applause. They set up an agency-wide incident management team, liaised with other countries and the European Commission, and alerted UK medical staff to the outbreak. And perhaps most impressively of all, the HPA microbiologists were the first in the world to sequence the E. coli genome. They have made the sequence data public, and it's now used by the International scientific community. That's the kind of work that we will make sure is safeguarded within Public Health England. I've recently been to the Informal Health Council in Poland, and I have to say I felt quite proud of the work that we've achieved. Other countries were hugely impressed at all that we've done. We have had tremendous support from local authorities taking on the role of delivering public health services, and it will involve quite a lot of staff movement, with those in PCTs shifting over to local authorities. So again, we're involving the NHS, local government, the department and unions, but we're also developing what we're calling an HR concordat that sets out what people can expect nationally while still allowing local flexibility. I know that a lot of people feel anxious at the moment. Change shifts the sand beneath our feet, and it can make us feel very unsteady and unsure. People want to know what's happening in many ways. This is the most difficult bit. That bit of transition is very hard. But the new system will also see opportunities. Change can be a threat, but change can also be an opportunity. New forms of career progression and training. And there's no doubt that there is a great deal of enthusiasm for rejuvenation in public health. Public health was one of those things, it happens a little bit to community services, that people stand on platforms and say, well, of course, we mustn't forget community services, and then we spend the rest of the time talking about acute trust hospitals. And it's the same with public health. We always say, well, of course, we mustn't forget public health, and then don't feel we have to mention it ever again. And this is to change that. But of course, this is a work in progress as well, and we need to develop some issues further. So we need to continue to work with local government, public health practitioners, and the NHS to make sure that we continue to be effective. So soon we will be producing a series of public health system reform updates. They will define and put the detail in the design of the new public health system. Things like the role of public health in local government and the Department of Public Health, how we will track public health outcomes and improvements, how Public Health England will actually work operationally, details of those funding allocations and health premium, and indeed the workforce strategy. I believe very strongly that the new approach can help achieve the things that we have all been striving for decades, helping individuals, families, communities live better, longer, fuller lives without those inequalities. But I don't underestimate the task. If it was easy, somebody would have done it before. For too long we have crisis managed health, dealt with the consequences of poor public health. We've paid lip service to public health, always giving it that mention but never making it a priority. And that's, as I say, not to say achievements haven't been made, they have. But we need to do much, much more so that the public's health is improved and, crucially, good health can be distributed fairly amongst us to all, so everybody has the same chances in life. Thank you very much.